next 15 or 20 minutes, I hope to be able to give you guys some high-level updates from the liver meeting from this year as it pertains to hepatitis B as well as hepatitis D, focusing primarily on treatment of hepatitis B and D. And I have some disclosures at the bottom, although none of them are specifically related to this talk. I will be discussing some off-label medication usage as well as some investigational agents. So just as a brief overview for setting the stage for what we learned at the liver meeting, I think it's important just to think about what are our main goals of hepatitis B treatment right now. So our big picture goals currently are to prevent cirrhosis, liver failure, liver cancer, and generally death from hepatitis B related manifestations. In addition to those goals, we have some markers of treatment success that we currently follow. So these include normalization of liver tests, suppression of virus, E antigen loss with conversion to E antibody, surface antigen loss with surface antibody conversion, and generally improvement in liver histology, including both inflammation and fibrosis. The surface antigen loss really is sort of our main goal of treatment, although it's currently uncommonly achieved. And I think it's also just important to remember who it is that currently is being recommended to be treated, and this hopefully will change, as Dr. Gish alluded to, with some upcoming recommendations. But right now we're focusing treatment on those who have immune active chronic hepatitis B. So these are patients that could either have E antigen positive or negative status, they have high viral loads, and they have liver inflammation. The cutoffs for the viral loads are different, whether you have E antigen positive or negative. But in general, a higher amount of virus, inflammation in the liver, and potentially fibrosis or damage, these are the patients that we're targeting for treatment because they're the ones in whom we can affect the most successful outcomes. Other things that we consider when we're treating patients include if they're co-infected with HIV or hepatitis D or hepatitis C, usually those patients get treated. If they're cirrhotic, they get treated. If they're immunosuppressed, they get treated. If there's a strong family history of liver cancer, we often would treat those patients even if their labs are pretty normal to reduce their risk of cancer. If it's a pregnant woman, as it pertains to the entire Massachusetts delegation of our perinatal team here, if we have a pregnant woman with hepatitis B who has a high viral load, they tend to get treated with tenofovir-based therapy starting at week 28 or so, at least as of current. And I'll show you some data that is interesting with that regard coming up. It's important that we stage our patients before we treat them just to get an idea of their cancer risk and also how successful we can be in improving their liver disease. We also try to screen all these patients for hepatitis A immunity and vaccinate them if they're not immune. We generally recommend avoiding alcohol, and we vaccinate household members if they're not immune. In terms of which therapies we can use, this will probably be a talk later this year, but just as a high-level slide, I thought this was a nice graphic from the liver meeting, just highlighting which medications we typically use. We have 3 first-line oral antiviral therapies: entecavir, tenofovir disoproxil fumarate, and tenofovir alafenamide. If you have a run-of-the-mill chronic Hep B patient, any of these treatments are fine. There are some specific scenarios where one treatment may be favored over another, as illustrated in this slide. In particular, right now in pregnancy, the tenofovir disoproxil fumarate tends to be the most commonly used. And in patients who have a history of renal or bone disease, tenofovir alafenamide tends to be the more commonly used one. How effective are our current therapies? This was just a table from our AASLD guidance, but just as a whole, these medications are very effective at suppressing virus. It makes sense here that an E antigen positive patient who has a higher viral load at the end of a year, it's a little harder to suppress those patients than it is who start off with a lower amount of virus to start like an E antigen negative patient. But generally about 2/3 to 3/4 of patients who are E antigen positive will be fully suppressed by a year of antiviral therapy. And if they're E antigen negative, about 90% or more will be fully suppressed after a year. What's important here, I think, is the second circles, which are the surface antigen loss. And what you'll see is that if our goal is to help patients lose production and replication of virus and go into some kind of functional cure, we're not doing a great job of that with our current therapies, and roughly 5% or less of patients are achieving that goal after many years of therapy. And I just wanted to highlight that our current monitoring strategy includes monitoring liver enzymes in a metabolic panel, as well as a viral load every 3 to 6 months. Some of these medications may require a dose adjustment for renal dysfunction, so we usually make it a complete metabolic and not just LFTs. We do screen for cancer per current guidelines, and if somebody's on treatment and their liver tests start to go up or their DNA goes up, we would assess for adherence, look for superinfection with hepatitis D, check for a new co-infection, and we would look for any other reasons why their liver test could be high. And in these days, they had COVID recently, for instance, could make their liver test go up. A lot of patients want to know, when do we stop therapy? And because we don't currently have an available cure for hepatitis B. Again, the goal here is to lose surface antigen and develop surface antibody to achieve what we're calling a functional cure right now. But this is uncommonly achieved. It's confusing what is a stopping point based on our current guidance, whether somebody's e antigen positive or negative. If we stop the treatment too soon, we might flare their hepatitis, we could induce drug resistance, and we might increase their risk of poor outcomes like cancer or liver failure. But if we treat patients too long, we're wasting money and risking potential side effects of these medications. So this has been the constant balance that we're trying to play in our world right now. So what I hope to show you with some of the updates from the liver meeting are where we're moving the needle a little bit with regard to our current therapies, as well as where we're going with future therapies. So I'll just start with a couple abstracts, and these are in the realm of clinical outcomes. So I mentioned that right now we're basically treating these immune active chronic hepatitis patients. This was an interesting study out of Taiwan where they kind of just treated patients who were in an indeterminate phase of hepatitis B, who so didn't necessarily meet the criteria for treatment right now. And they offered them therapy and compared them to the patients who were untreated. And what they found was that there was a 70% risk reduction in liver cancer among patients who were treated even in that indeterminate phase. But I did want to highlight here, though, is that even in those who were treated at 15 years, there were still over 10% of patients had liver cancer. So while it is a risk reduction, it's not a risk elimination. So it is important to continue cancer screening in these patients, even when they're on treatment. But it does raise the question, as Dr. Gifford alluded to in the introduction, should we be treating more people because we can reduce the risk of cancer if we consider broadening who we're treating? And this gives us a little bit of hope to move that direction. There were a couple of abstracts. There are actually several abstracts. I just kind of pulled out two that I thought were relevant to potential stopping rules. So right now we don't have clear stopping rules, and Taiwan again kind of helped us out here because in that country, for whatever reasons, patients are often limited to 3 years of therapy. So they have natural data where they can evaluate who does well after they stop therapy. And among patients who had stopped therapy, they found that you could measure the surface antigen quantitative levels at the end of treatment. And if the level was below 100, then there was a higher likelihood that those patients would eventually lose surface antigen in the following years stopping therapy. So the idea here is you sort of treat to provoke an immune response to lose surface antigen. And among those who had the lower surface antigen quantitation at the end of treatment were the most likely to achieve that sort of functional cure. And then there was another study out of Taiwan as well, where they looked at patients who had stopped therapy after being treated for at least a year. And they found that the patients who sort of started treatment while they were having a flare were the most likely to achieve that goal of a quantitative surface antigen level less than 100 at the end of treatment. So if you go into treatment with a higher ALT and more virus production or higher surface antigen level, those were the patients that were most likely to be able to have a functional cure once you got off of treatment. So overall, these data suggest to me that surface antigen levels can predict surface antigen loss when you come off of therapy. And this may be one of the things we should look at in stopping rules as we come to those in the future years. Now, this was a really interesting oral presentation that was presented, and this is relevant also to all the perinatal people out there. So Calvin Pan had presented an abstract looking at pregnant women in China who were e antigen positive, who were pregnant. And currently the standard of care for these patients is to get tenofovir starting at week 28. If they have a viral load over 200,000, they get HBIG after the baby gets HBIG after the baby's born, and also vaccination is started. And what they wanted to do is see, could they eliminate HBIG because HBIG is expensive and hard to find in some countries. So instead, they had another group of women who were started on tenofovir at week 14 to 16, sorry. And they also vaccinated the babies, but they did not use HBIG. The tenofovir was stopped at delivery. And what they found was comparing this regimen of starting tenofovir in the second trimester instead of the third trimester and eliminating HBIG was able to eliminate mother-to-child transmission in their per protocol analysis and was well tolerated. So, the implication of this is, could we potentially eliminate HBIG and still effectively eliminate perinatal transmission by starting antiviral treatment earlier in pregnancy in higher risk women? So this is interesting and obviously not standard of care yet, but could be something to come. So let's move a little bit onto current or future treatment targets. And I just have here a schematic of the replication life cycle of hepatitis B virus. I don't expect anyone to remember this, but just to know that there are multiple targets of treatment that are being investigated currently. And here's like a table view of some of the compounds of development. And at the moment, there are more than 40 compounds in development. There are a few key categories of antivirals that are being looked at. So I would look at replication inhibitors, which include these capsid assembly modulators. These tend to be oral medications. There are interference or translation inhibitors, things that inhibit the virus from getting into the cell, interfering with its production, as well as with the release of surface antigen. And these are generally injection-based therapies. And then there are also immune modulator therapies, things trying to provoke that surface antigen loss and immune response to be more favorable. And these include oral and injection agents as well. And these stars kind of represent where most of the action was from the liver meeting this year. And I'm not going to go through all the studies, but there were more than 10 studies that were presented in early phases of phase 1 and 2. I'm just showing here a little bit of data to kind of give you some hope that there's stuff coming. None of it is imminent, but there's ideas here on how to get this to happen. So one study was a study that was phase 2B, and it was looking at patients who were chronically treated with oral antivirals that are currently available with virologic suppression. And then they had 2 more drugs added. They had a translation inhibitor, a small interfering RNA molecule, as well as a capsid assembly modulator molecule given with their antivirals. They were treated for about a year, and then those medications were stopped. And they followed them for another year. What they found was that this combination did not lead to surface antigen loss. However, they were able to keep over 50 or 40% of these patients off of antivirals for over a year. So the idea that maybe there's a regimen that could lead to a time-limited therapy, because right now our treatments tend to be indefinite for most patients, giving some clues as to where this may help. Another study that was presented looked at a different translation inhibitor, an antisense oligonucleotide. And this was given also in patients who are chronically suppressed with antivirals. This is an injection-based therapy, and they looked at a bunch of different ways to administer it, either 12 weeks, once a week, twice a week, 24 weeks, different doses. Busy slide on the bottom here, but the bottom line is that patients were able to lose surface antigen with this drug and have a time-limited therapy in about half the patients. So, there's some signals here that this may be a molecule to look at, maybe in combination with other things moving forward. And then there was another abstract where it was combining a translation inhibitor as well as an immunomodulator therapy. And this was presented by Ed Gain from New Zealand. Basically, they were looking at what's the reduction in surface antigen levels with this combination. And they found that with this combination, they were able to get everybody in the study to have a surface antigen level less than 100, which, as we saw from some of the other abstracts, is a key indicator for a potential surface antigen loss in the future. Now, this study did not go far enough out to see how many people actually lost surface antigen, but it's showing you that maybe this combination is effective at suppressing surface antigen production. The challenge with immunomodulator therapies is that they have more side effects. And we know from drugs on market like nivolumab that's potentially being used for liver cancer. These have immune activation issues. So patients can get autoimmune disorders like thyroid disease as well as colitis. And these are things that we need to learn more about. They're different doses, they're different medications potentially, but they're risks that some of our patients may not want to take. But again, sort of putting some of these pieces together to know where we head in the future. So a high-level summary for the hepatitis B here is that there are emerging therapeutics. These have different categories, including replication inhibitors, which don't seem to reduce surface antigen that much or restore the immune response, but they do suppress DNA well. There are translation inhibitors that really do drop surface antigen and may help with the immune response. And immunotherapies have variable suppression of surface antigen, but they do have immune responses that are helpful, but they can have a lot of autoimmune side effects. And future combinations will likely need to include agents that do some of all these things. So inhibit replication, reduce surface antigen, restore immune control, but also be well tolerated. And right now, surface antigen loss seems to be the current target for these functional cure studies. I'm just going to move on to hepatitis D briefly, just have a couple slides on this. So we know hepatitis D or delta hepatitis only affects people with hepatitis B. You could be co-infected at the same time or super-infected at a later time. And when you have both of them, you're more likely to get cirrhosis or liver cancer or die from liver disease, which is why we care about it. We think there's about 20 million people that are infected around the world. The screening test is hepatitis D total antibody, and the confirmatory test is RNA. And as it was alluded to earlier, it's challenging to get these tests. They're not CLIA certified, and they are variable depending on where you go in terms of what you can get. Even at my own institution, it wasn't until like 6 months ago that we could get the total antibody. They always just sent the IgM. So, it's something that is coming in the US. And at the moment, there are no approved therapies. You can use pegylated interferon if you have proof that they have viremia or an acute infection with this. But none of us really love giving interferon. It can be useful in these patients if they're really sick, but it's not a drug that patients generally love either. We do currently try to screen everybody at baseline who has hepatitis B, so we know if they're co-infected. And we generally recommend clinical trials for all patients who we find that have hepatitis D. In Europe, there is one medication that's approved currently called bulevirtide, which is an inhibitor to viral entry. It's also an entry inhibitor for hepatitis B as well. And it's been conditionally approved since 2020 as a daily injection therapy there. So at the meeting, there were just a couple Hep D things I thought were relevant. The main one was there were two posters that looked at screening. And in both studies, they basically show us that there's room to improve screening. So in the first study, which was a 2-center study, they found that only about up to 30% of patients with hepatitis B at their sites had been screened for hepatitis D. And in those who were screened, the prevalence was as high as 9%. So it definitely was something to not miss in these patients. And in another study that looked at HIV, HBV co-infected patients, and among those, 4% had hepatitis D antibodies, but among those that had antibodies, only 40% had positive RNAs. So again, room for screening improvements, and we're probably missing this out there. When it comes to treatment, again, we don't have any approved treatments in the US. There was some real world data coming out of Europe for the use of bulevirtide there. And what they found was that it generally was well tolerated out to a couple of years of therapy, but it's not a cure. And what it does is it does lower virus load, it improves liver tests, it improves liver function, but most of these patients need to remain on treatment for a long time. And so, we now have data out to 72 weeks of treatment since it's been approved. So my take-home points for hepatitis D are that, and in general for the AASLD, are that we have effective medications for viral suppression in Hep B, but we're not yet curing patients. The current medicines will reduce your risk of cancer, and potentially even in those who may not qualify for treatment by today's guidelines. There are many treatment options coming. What exactly the future cure is going to look like, we're not sure, but we have a lot of options there and more to come. We need to start considering who and when we are to stop therapy in. And it looks like surface antigen quantitative levels may be a piece of that puzzle. And we should definitely screen for Hep D in patients with hepatitis B, as we're definitely missing patients. Even though we don't have currently approved therapies, we can at least link them to more effective cancer screening and monitoring for their liver disease. And with that, I'm happy to take any questions.
Great. Thank you so much.
Oh.
Any questions, comments from the presentation? Go ahead, Dr. Gish.
Dr. Fink, that was great. Thank you so much, both simple and complex. I wanted to comment on the Delta issue and also ask the question, do you have Delta antibody total and PCR quant available to your clinics in Philadelphia? Because Catherine will remember how this started 1.5 years ago with LabCorp. What's your access right now?
It's not great. We have it through Quest, which is the only commercial lab that we can get it through right here right now.
So just a comment.
In-house, they'll check a IgM, but the IgG and the RNA get sent to Quest.
Okay, yeah, Quest has had the total antibody and quant PCR validated as an LDT, which is a CLIA equivalent, because they are CLIA approved in some states. It depends on how they do their application. So Quest has it. ARUP has total antibody and quant PCR. Mayo Clinic has total antibody and quant PCR, and LabCorp should have them within a couple of months. They've been working on it for the last year through a lot of different sources. So we do have really highly reliable antibody and quant PCR tests today. And I believe this is at the standard of what you would have for FDA clearance, even though these local labs haven't gone through those steps. Abbott's got quite a bit of interest in doing this, although I haven't seen a signal they're going to get FDA clearance. They have it available on their platform. Roche has PCR on their platform, and that's what AREP is using. And they're actually going to start using a much more advanced version of, it's called a microchannel assay that Roche will have out. So the bottom line is, in the US today, you can believe an antibody and a PCR test result as highly accurate and probably meets what would be required for FDA clearance. That's the good news. And hopefully LabCorp will deliver to us quality throughout the country where they have contracts.
Yeah, thank you. And, you know, particularly in Philadelphia, when most of our managed care payers capitate to LabCorp, it would be really helpful to have that access.
Can I make one more comment, Catherine, Dr. Fink?
Sure.
So there was a debate at AASLD between myself and Anna Locke about following the guidelines or treating everyone. And that's available through the AASLD website. I have the link also that maybe you could send out to everybody. But my major point was that we've had guidelines for 20 years, guidelines for 20 years, and we still have 2 people dying every minute. The guidelines have made no impact on the death rate. And we have clear data, even in indeterminate, gray zone, low viral load patients, that if you treat them, that you can reduce cancer risk by 70 to 90%. And clearly, if you're treating people with active disease, you can prevent cirrhosis, transplant, and death from liver failure with our nukes. So the move among the KOLs, we have 40 KOLs that we organized through the Hepatitis B Foundation, and 98% of those KOLs said we have to simplify things, risk-based testing has failed, and treatment on these guidelines has failed. And we now have enough data to say treat everybody. And there's models of even treating everybody who's surface antigen positive, big one in Uzbekistan by Homi Razavi. So the trend is going this direction. And I will just make the statement, we have the data today. The guidelines tend to trail the data by 3, 5, 7 years sometimes. So sometimes you have to move ahead of the guidelines because the guidelines take too long to get reconstructed. But I'd love to hear your input.
I mean, I would also be in favor of treating more people. I think the one challenge that isn't easily solvable is that it's a hard sell for some of these patients to go on indefinite therapy for now. So I think if we had concomitant stopping rules that were better accepted, I think it would be an easier sell to start people earlier.
You know, I think your comment about indefinite is definitely better than forever, but now I'm telling people that it is going to be finite therapy because we have over 30 drugs in development and we're going to have really good treatments within 5 to 10 years. So I said, look, we're going to rediscuss this yearly. And I'm optimistic within 5 to 10 years, we'll have short-term treatment with a high functional cure rate. We want to really give them hope. And I think that's real. I don't think I'm gaslighting anybody.
Yeah, I definitely say that too. And I'll tell them, you know, I'm pretty confident that in your lifetime, in your short lifetime, we're going to have better options. And they say to me, well, I'm going to wait for that one. So that's the debate. But I think if you have somebody who's got a strong family history of liver cancer who doesn't quite meet the criteria, that's a much easier sell. You know, but I think stopping rules would be helpful. And we were just now starting to be able to even get quantitative surface antigen levels in the US. So that's something that we can get.
Right.
We have to figure out how to use that effectively too.
Yeah, Quest has had Quant S for 5 years, LabCorp for 2 years. I'm trying to get AREP to get Quant S online. I have a conference call with them. I don't know about Mayo Clinic, but it's not completely available, but Quest is almost everywhere, but not quite.
Yeah.
Since we're talking about treatment and treatment duration and that sort of thing, I want to pull in maybe Melissa to get her perspective here on treatment as somebody who has that lived experience. I think.
Sorry.
Oh no, you're good, Melissa.
Hi. Yeah, I guess I've been taking entecavir for the last maybe 2.5 years. I actually I think you when you first hear it, it's a little disappointing. But then I guess once you get used to it, you take your pill every morning, and it's not, for me, it's not too difficult to be compliant. And but on the other hand, you still have to go to your hepatologist every 6 months to get blood work, to get an ultrasound. So I think that probably is a little more onerous from my standpoint.
Yeah, thank you. Thank you for sharing that. And I see Wendy also has her hand up as somebody also with experience personally on this.
Yeah, thank you. What Dr. Gish mentioned about that talk at AASLD, I was actually one of the recorded speakers, presenters. I think the comment here in terms of, I think patients are not a homogeneous population. So even for people who are in that indeterminate gray zone, which I was for a decade, but the established current guideline made me like not able to get it. So I think it's important that these guidelines provide baseline, right? From there, then medical practitioners here have a conversation with the patient and figure out what's right for you and nuance that. But if the guideline right now, if you're in the gray zone, is don't treat, that is actually setting a baseline that's very different, that cuts off a good portion of population who are willing, wanting, seeking treatment, as the studies have shown. So I just want to share that.
Yeah, thank you, Wendy. I think that's a really great point. Not only just like each patient individually is a person that may have specific circumstances and different needs and wants that should be kind of dialogued. Yeah.
I would hope that going along with broadened treatment would also go along with the idea that we don't need prior authorization anymore too. Because, you know, the other challenge I fear when you treat everybody is that every December and January, it's going to be a craziness to try to make sure everybody's approvals are still good. And I worry that everyone's going to flare in January. Yeah, I think, again, the advocacy part of it here is going to be to try to eliminate the need for prior authorization as you allow for more broad access to treatment.
I just also want to add something about the cost of treatment, because even though these are all generic drugs, there's still, the insurance companies still want you to pay a pretty hefty copay for these drugs. And that's probably a bigger burden for a lot of patients.
Yeah, definitely. Thanks for pointing that out.
Can I comment on the cost for a moment? I've been doing a lot of homework on this recently.
Sure.
And there are a number of co-pay cards that or discount cards, GoodRx, and something called BuzzRx. I just met this last week. And the cost is very, very low per patient per month with these cards. I went to my federal clinic in San Diego to take some entecavir to Vietnam with me in December for one of my patients. And I bought 1 year's worth of entecavir for $50.
Wow.
So the federal clinics, the FQHCs have contracts. I don't know if it's everyone, but mine has a contract. And that's how cheap their cost is for entecavir. I got it at cost. I don't know what their markup was, but it wasn't going to probably be $150 a year. So the prices are low if you go down certain channels. But the insurance companies recently, for all my patients on TAF, have been forcing me to switch them back to TDF, because the generics came out with a big price reduction of TDF over TAF, even though TAF, when it came out, it was lower than TDF. So there's a price war going on that's forcing us to go back to use a less good, it's a very good drug, but it does have renal and bone issues. So there is a battle going on with that as well. Lots of action.
Definitely. Yeah, that's something we've been fighting against as well. I also put in the chat box a link to a list of treatment access programs and from prescription drug coupons, things like that in the chat box for those that are maybe helping clients navigate challenges with that treatment for Hep B. Also, so I just wanted to note too, based on the Delta testing, I think we were chatting with some of our colleagues at Prevention Point community-based clinics in Philly. I think one of the challenges related to just access to Delta testing in general is like a huge barrier for local clinics. So that's something that we certainly could work on as well. I see Lori has her hand up, and apologies, I noticed you had it up earlier.
Oh, that's fine. It's a separate question. Thank you for the great discussion. I was interested in the definition of surface antigen loss, whether it's a percentage decrease or a complete elimination.
Complete elimination.
Thank you.
And I'll comment on that too, to build out, is that the tests have a limit of 0.05, I think it's international units per ml. And that if it's below 0.05, it's negative. But if you test those people with new super sensitive assays, 30 to 70% remain positive. So this is an arbitrary cutoff that Abbott and Roche designed into their assays. Unfortunately, it's exactly the same cutoff for the two main assay platforms. But negative means less than detectable. It doesn't mean that they're truly negative. And that's why we're using the word functional cure, because we're not going to get to a complete cure until cccDNA is gone, or sterilizing cure until integrated virus is gone. But when people get less than 0.05, their natural history, chances of cirrhosis, death, cancer, transplant, other complications of hepatitis B is minimal. It's not quite natural history of a healthy person, but it's close to that. That's why that 0.05 is so magical.